Thanks everyone for joining us today. My name is Vian Vu and I'm a physical therapist. Today I'm going to be going over the neurocognitive considerations after ligamentous injuries for rehab and performance. I have no disclosures of note, and Ryan Sexton is here and he's with Synaptech. I did my undergraduate in kinesiology at San Jose State University, did my DPT at University of the Pacific, I did sports residency in Gardner, Wisconsin. I did my D1 fellowship in sports at Wake Forest. I'm currently a resident faculty here at Samaritan Athletic Medicine, where we work with Oregon State athletes. I also serve on the DEI committee. I have a little YouTube channel and then serve as assistant to Dan Cobian of the research committee of the American Academy of Sports Physical Therapy.
Performance. All good. So I looked at this topic actually in undergrad for the performance side. So this is a motor learning lab. This is Dr. Will Culture, and all of my partners in the lab really helped me out a lot in their own professions and helped me find the research. So it's something I looked at years ago, and then now that I'm a physical therapist, I started looking at it more for injuries. But a part of that lab, let me continue. PowerPoint. But from that lab came a lot of PhDs in human factors. Darius was over at Stanford, and now he's over at Colorado. Shane owns his own company now, specializing in developmental optometry. We have Jordan, who's a performance coach with private practice. We have the GOAT. She taught us everything. I still do research with her. And then me, I'm a jabroni. I have 4 manuscripts that have not been submitted on my desk still. So everyone else is doing great things over there. All right, so today I hope to identify what neurological changes happen after an injury. I think we all know there's weakness, there's pain, but what goes on inside the brain? So we're going to talk about that. After, we're going to understand exercise prescription. So we're going to get really detailed. The good thing is I'm like 100% positive everyone here does what works, except if we're more thoughtful about them, we can be more effective in addressing these cognitive changes. And then we're going to look at current evidence for vision training and performance. And that's when we're going to get into Synaptech, and we're going to also have a live patient come in here. She doesn't have a ligament injury, but she's certainly going to work on some dual task activities that might help her performance while she's rehabbing. So before I even get into all that, I want to go over that we don't want to skip the basics. I think a lot of this, there's a lot of like high-tech stuff, a lot of new concepts, but if we skip the basics, we're not doing any good. In sports, normal life, we can get by with a normal tire, right? Our legs are normal tires. It's a nice, easy path. Sometimes there's a little bump on the road. We can get past there. If we skip the basics, though, we're going to not prepare them for what's in sports, which is the frozen tundras of Wisconsin. So similar, if we rehab them just to, whatever we think is okay, they're going to be able to drive on there, but it gets risky. They're going to have occasional times where, they definitely slipped, but they dodged it. But sooner or later, they're going to get in a car wreck. So what we need to do is we need to bring them back to normal, but we also need to bolster them to meet the demands of their sport, and sometimes add a little extra, whatever modalities or kind of exercises and training we might have for them to endure that. Unfortunately, what do you think we have nowadays in PT and rehab in general? We have this, right? We didn't even bring them to their baseline, or we find Instagram videos that are all fancy, but don't even have foundations to move on the road. So we got to make sure that we don't skip the basics. And right now, everyone's probably saying, this guy's crazy. What do you mean? We do a pretty good job. That's not what the surveys say. So Greenberg in 2018 looked at a survey of 2,000 physical therapists, which I consider a little higher level than usual. They're in a sports organization. And 80% of them did strength testing. And only 56% of that considered mental muscle test sufficient, which we all know is pretty poor. And then we talk about wellness and fear all the time, but only less than 5% actually screen for it at the end of the rehab. And then Toole, she looked at athletes up to 4 weeks out from their discharge. So within a month of their discharge, she had them come back in and she tested them on all our traditionally tested stuff. It's not anything fancy. It's no force plates or anything. Just a few hop tests, functional outcome measure, strength testing. But she found it was only 53% passed within a month from being discharged. Strength, only 28% passed her quad strength test. And then combined cluster, only 14 met all criteria. But I mean, that's 2017, so things have changed, right? Sorry, guys. So it did improve. Meredith, who's on this call, she looked at patients from around 2015, so fairly recent, based on what normal evidence is, and definitely improving, but still around only 50% of our athletes are passing their tests as they should. So, I mean, do the tests even matter? Like, maybe that's why we're not testing, because we don't have any proof. That's the same study where Tool looked at athletes a month after. She found that the criterion cutoffs for both strength tests maintained the same level, or those who passed it maintained the same level of sport and participation compared to those who didn't. So it does matter. In a little literature review in 2015, Folio looked at level 1 cutting sports in general and ACL injury. 81% return to sport, only 65 return to prior level, and 30% re-injured themselves within 2 years. What do you guys think happens when you test? Hopefully that's good noise. Well, Arendelle followed a cohort of 40 people, and this was Division I soccer players over 2 years, and she had just a basic test cluster just like Tool had, and there was 100% return to sport at that point, 95% return to prior level, and only 2.5% re-injured themselves. So we can only take it with a grain of salt because you need a much larger sample size from it, but just comparing 2 years to 2 years, the findings from 2 years there, we could say that there's some evidence there. And then Grindham 2016 also showed that if you pass your test, you've got about a 5% chance of re-tearing or re-injuring yourself at 2 years, whereas the other group hit about a little over 36 to 40% ended up injuring themselves without passing the test. So we can give everything fancy, but it's important that we still do it. But again, do you think it's improved overall? What if we wait longer? What do you guys think happens if we wait 9 months to a year? Does outcomes improve? I hope so, but not so much. So Kate Webster, she looked at youth athletes returning to sport, and they did not disclose if they got tested or not. Just they had a delayed group, which waited longer than a year versus non-delayed, which was 9 months. So even traditionals. And what they found was if you combine both the contralateral and graft ruptures, even now, return rates remain over 30% despite increased standards of testing and 9 to 12 months return, even past 12 months. So for some reason, I think, yes, we should test. That's the easiest thing we can do right now. But we still don't know why this is happening. Maybe we're not thinking right, or it could possibly be that the brain has a problem too. And that's where a lot of the emerging concepts or research is coming out of. And I think if you see the conference, me and Jason, or me and Ryan were just talking about it, but you see at NATA and TSM, a lot more topics going out in this area. Actually, shout out to Christina. She just got accepted for talking about this topic. So a lot of us like to consider what happens after an injury, right? So there's mechanical instability, surgery fixes that. There's motor control issues. There's sensory feedback that's a little hard. You're not as strong. There's loss of information. There's proprioception deficits. And then there's pain. So we all identify this, but we don't think about what might be causing it, or a few of us do. And that could be the whole kind of brain changes there. Unfortunately, I understand this. Sorry, guys, we have to go over neuro again. Who's excited for this? I don't think anyone is, right? Yeah. All right, so I'm going to do my best. I did have to call General Meredith to help me out, but we're going to keep this a bit brief just to help me out with complexity and also get you guys on the part that you actually care a lot about, which is the treatment. So just to make it easy, we're going to think about it as a car. As much as I hate the car metaphor in PT, we're going to think about it as a car. So we have, this is going to be called the cortical spinal pathway, and that's going to relate to the brain and the brain stem. And that's kind of our engine. That's where the neural drive, the throttle, all that powers the whole entire car. But when you look at a car and it's not moving, we can't just assume it's the engine, right? It may be happening here. So we kind of have to put that as a spinal reflexive pathway. So when you, just like when you diagnose a car, you take it to the shop and let's say they put their little machine in, they try to read all the codes. They can't figure it out, so they go by hand through each area to make sure they can find it well. So in the same way, there's ways that we can measure stuff too. So with the cortical spinal excitability, one way to look at it is using TMS, which is basically you send an input into their brain, and that elicits a a predefined motor output or however high or low you want to put it. Some things they look at is resting motor threshold, and I'm going to repeat all this throughout the session so you guys can get the context of it with rehab. But the higher the resting motor threshold, that's not good because it takes them a greater output to get out of that resting state. Active motor threshold, so again, a higher active motor threshold, it takes them more drive to actually achieve that minimal state that you predefined. And then motor evoked potential is just how much motor drive there is. So they can find all those values using this. And then everyone knows about H reflex, right? So you send an input in. So that's what spinal reflex excitability is. They look at the Hoffman reflex. And then the Hoffman reflex is just a proportion of the pool. And then the M wave is what is the total motor neuron pool in the spinal cord. If you remember, the spinal reflex, it goes into the spinal cord. It doesn't go up to the brain. Acts in there. You have an inhibitory factor on the opposite muscle, and it shunts out another motor output signal there. So it doesn't detect up here. We can isolate it somewhat up here. So we look at the H&M ratio to see how much of the total motor pool is able to be activated with that outside spinal cord system. Okay. And again, I'm all going to repeat this. So just a quick review of what was summed up pretty recently. So looking at quad activation and strength, is there any surprise when you guys read this? No, right? Between the involved and uninvolved limb, we both know the quadricep's a little bit weaker. As for activation as well, those are both lower on looking at the involved limb and when you compare it to healthy groups. So this means the car is not starting up or moving like it used to. We don't know why. We just know that the quad for some reason is not working. So if you look at cortical spinal excitability, again, this is the upper part, this is your brain, this is the engine. There are significant increases in motor threshold. And this one, I believe they looked at active motor threshold. So you had to produce more drive for it to move between limbs and then also between healthy groups as well. There was no significant difference between motor evoked potential. So both have that same neural drive, except it took more to actually get them to actually produce that kind of motor response. So this means the engine still has plenty of horsepower, that MEP, but it seems to be the throttle maybe. So another part of the brain that might be the issue. And finally, looking at spinal reflexive excitability, there is significantly decreased H&M ratio. So there is a lower proportion of the total motor neuron pool that could be activated when you compare to the healthy group. So it affected both limbs, but to the healthy group is a little different. So this means so if the throttle has an issue, again, up here, we're going to try to put new racing tires on it just to get that speed somehow. So this is your spinal reflexive excitability is likely compensating in some way for that lack of throttle. They're going to find it somehow. That's what this study shows. And this was a systematic review as well as a meta-analysis on all the research looking at this for patients with ACL reconstruction. Any questions so far? All good. Another we can look at it is functional MRI. So Dustin Grooms did this study with his group, and what they did was they had someone do MRI of their brain, and during this they put their patient on a bolster, and then they fixed their ankle so that there wouldn't be any, there'd be less artifact on the imaging, and they simply just did a short arc quad, short arc quad, so they worked only the quadricep muscle. And they compare this between people who were up to 5 years out from ACL reconstruction compared to healthy matched groups. And what they found was all this complex stuff. So different areas of the brain in the ACL group either decreased or increased. So before I even go into it, can anyone list out or name some stuff that they see impairment-wise with their ACL patients? I'll say one, so quad weakness on, I'll say the injured leg. Anything else that we can think of?
Reduced balance.
Reduced balance, okay.
Proprioception.
Proprioception, great. Sometimes front knee pain, I don't know, it's overloading, but I just see patients really struggle with that. I know I struggle with that with a lot of patients. Anything else like that?
Yeah, swelling.
Swelling, yep. Definitely.
Speed of force production. Power.
Rate of force, yeah, power. Excellent. Yeah, so interestingly, all what we see clinically kind of lines up. So the blue area means it's decreased compared to normal groups. And so in the ipsilateral cortex, the same side, that means it's going to cross over. There's a decrease in contralateral limb strength. A lot of us thought it was just maybe due to disuse, right? But it can actually be a neural thing where actually it's decreased overall. In addition, there could be decreased cerebellum activity. Again, so there's decreased input, balance, motor control. We would look at the orange, that's going to be increased areas of the brain. So the contralateral motor cortex, which is going to be the involved leg, you need increased motor drive just to get that lighting up a little more. And there's increased ipsilateral secondary somatosensory cortex, or somatosensory. So that's increased pain. Again, even 5 years out, this is kind of the average of it all. And then, of course, lingual gyrus, proprioception, that's decreased because the vision is going to be a higher dependence on there. So they're using their visual senses more to take in input rather than use their senses, because once you deteriorate, you see all that proprioception is gone. In addition to that, we want to look at not just like quad strength as above, like the MEPs and all that, but we also look like functional stuff as well. So Meredith, this was another paper she had done. And what she did is she compared visual, motor, and memory. So she had her athletes take the impact and just looked at the visual, motor, and memory aspect of it. And then she compared it to quad strength, function, active joint positioning sense, time to stabilization. And for that, they did a jump. So it's a maximal double leg jump landing on one leg. And they just looked at how much time it took for them to stabilize. And then they also did the classical highlighting and looked at functional MRI of the brain. What do you guys think they found? Any guesses? Correlations to that? So for when they compare visual memory, there is a negative correlation to joint positioning. So someone who has better vision is going to do a worse job when they're blindfolded and have to dissect their joints. So again, they're compensating with their vision system. And then when you look at time to stabilization, someone with the visual motor composite score, there's also negative correlation too. So the higher their motor, their vision score is, the worse their balance and time to stabilization is going to be too. And similar to Dustin Groom's findings, she found that areas associated with vision light up. There was no significant increased signals in the healthy controls during these tests, or when she did the imaging. So again, they're using their vision system more and not the brain. And this one was fairly, I think this one was not up to a year. I think this might have been 6 months out, but I may be corrected. So that's what happens after surgery, but what happens during surgery? So Ryan Starzicki published this one just recently, and this looks at during the course of rehab. And I want you guys to consider this. He was from Delaware. They have some of the best rehab. They follow all the recommendations that we should have. So what he did was he tested resting motor threshold, which is, again, how long it takes you to get the muscle active, and then motor evoked potential, again, the neural drive. Looked at quadricep strength, and he looked at it a few time points. 2 weeks after surgery. He also looked at it during a quiet knee, which is around 8 weeks, and then return to running, which could be as soon as 3 months, but the average is around 4 months then. And so resting motor threshold, if you can remember, that's going to be how much you need to activate that muscle to have it move to whatever minimal amount you want. So when you compare between healthy groups and their matched limbs, you can see that it took a lot more to kind of get out of there. Interestingly, and I struggle with why this happened too, but the non-surgical limb actually took more than the surgical limb. But the big difference is between groups, and that one we'll kind of talk about later. When we looked at motor evoked potential, again, that neural drive, how much they have, they had a lot higher, likely because they had to produce more to elicit that quadricep response. So between groups, it was significantly higher in the surgical group. Between groups, it was higher as well on the injured side versus the uninjured side. And then H&M ratio, so again, this is not your brain, but now it's the spinal cord. So when they looked at that, there's a significant difference between, although not as much. And then even at 4.5 months, it kind of normalizes. And then I believe this difference was significant for the first 2 time points too. So one caveat is like I don't think this is long enough for us to get a lot of useful information, but it does tell us that even with the best care possible, there seems to be still these cognitive changes within that brain. And so just to sum it up, for the first 2 weeks, there's decreased resting motor threshold between legs, but increased between both groups. This one, that's a confusing one because, again, the uninvolved, that's actually higher than the involved. But pretty much everything remains the same. And then it's only at about when they return to running that they get that spinal reflex portion equal in between legs, equal in groups. So the unfortunate part, though, is we talked about how when you have the H&M ratio increase, it's there to overcompensate for our needs. What do you guys think our rehab looks like at 4.5 months? That's when we do more complex stuff, right? That's when all this stays the same, though, and that compensation is kind of gone. So we actually might be a little bit riskier, and we're not addressing that yet. So it's important to understand these time points and what that looks like in our rehab and give that context to it. So now we understand the movement stuff, but what do you guys do to combat atrophy? How do you guys combat atrophy after ACL injury? When do you guys tell them it's going to come back, first of all? I try to tell them like I tell them they can get their strength back, but their muscle girth might not be there early on. I said that's going to take a while to get. But what do you guys think? What are things that you guys can all do to help with that? Takers. Not just say strengthen, right? Strengthen the heck out of it. BFR. Although with BFR, from what I understand, it just helps you decrease the muscle loss, not necessarily gains. But my old thinking was just strictly strengthen. And that's how a lot of us think about hidden factors of muscle atrophy after ACLR. So we can only see 10% decrease in muscle mass. So Lepley kind of has this great article on muscle atrophy and all these neural changes. So in the past, we thought it was similar. Oh, they lost girth because there's a disuse issue. They're not working out anymore. They're rehabbing, they're bedridden, they're on crutches, so you get that atrophy from there. But that's not actually true. There's actually a lot of neural components to this too. So what he proposes is that it's not just a disuse issue. So if you see the disuse, if we just follow the disuse model, you go to inactive, so they lose some muscle mass. It's atrophied, so you exercise, it's all gravy. But that's not an ACL injury. There's actually trauma to the neurological system. So ACL injury, those nerves aren't working well. So you can strengthen all you want, but if that connection isn't there, you're not going to get that. It's going to start atrophying, and you don't get that adaptation you similarly see. So you simply just can't strengthen. And this cleared up a lot of things for me because I remember in residency, I had a mentor. Like before me and Danny got there, we were meatheads. We were like, yeah, we need a squat rack here. We need to like lift heavy. Let's overload them. And loading appropriately is 100%. You need that. But I had a mentor there for years. He was just like doing all these, like little motor control exercises and what I thought was underloading. You put them on the biodex, you put them even at their 6 month time point, passed every test. And I was like, how the heck did that happen? So I think this kind of helps me understand better. And this also helped me understand as like a therapist from an ego standpoint that like just because you don't do something doesn't mean it's not effective, because at the end of the day, did it get what your intended outcome was? So that helped me think clinically short term, but also broader scheme about what could be going on. So I think he did a really good job of calming the nervous system, but really working on those little things, not over aggravating it and restoring those neural components there. In case he ever watches this, his name was Jeffrey Brett, by the way, so you can get some credit. What about before injury? This is crazy, right? And shout out to Meredith, she showed me this. And you got good old grind staff. We got Clayton from Creighton here. Creighton, let's go, Marcia. All right. Yeah, so this was a chance case study. So it's a 23-year-old female Division I basketball player. She was playing a pickup game, left non-contact ACL injury, no prior history of injury. She just happened to do 8 months of prior study looking at quadriceps activation and quadriceps strength. And so there they did drop jump landing for the right lower extremity, and then for the injured leg, 1 week before the injury, they happened to take the activation of the quadriceps, and even 4 hours before the injury, she actually came in for a retest of it, and then she injured it. So poor girl injured it. Within great care, 36 hours, got her in with a physician athletic trainer. Probably Terry was there too. They're saying it. What do you think was the first words they said? Probably. Who knows? Who knows what they said? What do you guys think? Hey, we should test it again. Yeah, for sake of science, right? So what they did was they actually tested it 36 hours after injury and said, all right, I know you just hurt yourself, but let's put you on the same thing and look at your activity. And what they found was, again, 1 week before, her quadricep strength was starting to decrease pre-injury, right before. And then you see her get injured 36 hours after. 3 months, it's restored quite well. This is activation, so central activation ratio, 100% means full activation. For normal people, optimal is about 90-95%. For normal people, it is 85% or better. And you could actually see a week before to 4 hours before it was below that threshold. And luckily with rehab, they restored that. But it's just an interesting case where what if it's like the neural component that has a big factor in these injuries? What if it's happening before our eyes and we just can't see it? It's blinded to us. And I think that might, again, it broadens my questions I asked. So is it not only biomechanics, but neural drive as well, right? Talk about a good warm-up. This is by the Delaware lab. So Celeste Dix and Amy Arundel both published studies on this about a cohort where they compared a group that did the FIFA 11 plus and that did not do the FIFA 11 plus. We all know it's well written in the literature that it's an effective program for injury prevention. But when they looked at biomechanics, with their model of dynamic knee valgus, so that combined model of movement, there wasn't significant change in there. Abduction, there was a significant change between groups, but for the most part, there wasn't any biomechanical changes. So that makes me think why biomechanical changes don't change, yet you get the same preventative factors from there, or effects from there. How about fatigue? We would think at the later end, right? Well, this one looked at a systematic review across several sports, and you can see that a lot of people injure themselves at random times. We can't really predict at what quarter, and even some you'll see first in the blue and red. We see there that a lot of them injure at the first one. So what if it's just we're not giving a sufficient neural drive to start the game with? That's just some thoughts. There's no concrete evidence, but it just makes you beg the question a little bit more. Other injuries, this isn't exclusive to ACL tears. Like I said, Needle talks about different measuring methods to look at the cortical and neural drives with ankle sprains and low back pain. Ankle sprains behave very similar. And then you see it in lateral elbow pain and also patellofemoral pain. You get some changes in the brain as well. So for part one, just review of what's happening to the brain before, during, after, we'll say possibly before. There are cortical changes after injuries, even if the patterns are conflicting, because some studies say this portion decreases, others decrease, but we just know there's changes that don't restore within years, even after they're playing again. Most agree visual processing is going to be used more, despite all the patterns are conflicting. You're going to require more neural drive to through the system to produce a good quadricep strength. And then compensation of the spinal reflex systems are increased, although it may level out in late stage rehab. And then traditional rehab with adequate testing can improve outcomes, but without neurocognitive factors, there might be a little typo there. You want to consider it just so you don't get stuck. So a lot of our patients do well, but what if the ones that don't? What if the ones that years out, they don't get their quad strength restored? They never pass their movement analysis test. So these are things you want to start thinking about. Even if they look fine, timeline, there might be things that we can help neurologically for them. All right. So we're ahead of schedule. Does anyone need a break at all? No? Awesome. All right. So next we're going to go to interventions. All right. So the first one, where you can help restore quadricep activation is neuromuscular electrical stimulation. Who does this at one time point in therapy? Everyone, pretty much, right? All right. Everyone here, at least. Okay. So this is a clinical practice guideline, 2017. So what a clinical practice guideline does is it recommends, it looks at all the evidence out there and then makes it concise for us, and it grades the evidence of recommendations for us. So surprisingly, a lot of people don't do it. Who sees braces and crutches? Do you guys see that more than you see people do NMES. Because for braces and all that, very low grade, yeah, I see a high proportion of patients do it. Yet when it comes to neuromuscular electrical stimulation, A grade, I see it less likely. And here, I see all of us do it, which is good. But I think once we get it out into the world, we can see less and less not do it. And there's barriers to it, the cost of it, the time. It's boring. Let's not leave that out. But it's still recommended to do it for 6 to 8 weeks, which is something we can easily do right away. Oh, spoiler. He uses ice. Everyone, I use ice, right? There's probably that you can get into debate with that. Who uses it? When do you guys use it? After session, mid session, or what? You guys look at me like I'm an animal.
At the end.
At the end, right?
Begin.
Yeah. Beginning, if you'd be good. So cryotherapy has actually been shown to increase quadriceps activation when you do it before. Caveat: these studies looked at it for 45 minutes of ice. I do it for 15 before. And what you can see is, again, quadriceps activation ratio, so it's out of 100% being 1. You can see for 45 minutes, there's a significant difference, a little different, but statistically significant at least, by using ice before rehab. Okay. What about the good stuff like ice and tens? They compared that to prior to exercise. What do you think they found? Similar stuff. So you have the control group here, you have focal joint cooling, so cryotherapy right here, and then tens right here. And then this is going to be your time points. So they compared, what's up, Zach?
What did the control group do?
Nothing. They just sat there and then remeasured their quadriceps activation and then isokinetics. They did it was isometric at 60 degrees, I believe, for quadriceps training. So they just, sat there pretty much. So the control group here, after 20 minutes, oops. All right. So the control group had decreased activation by 3.5%, whereas the joint cooling had 5.7% increased, and focal joint cooling was 45 minutes. I believe TENS was 20 minutes. And then there was a 6.4% increase after 20 minutes with 10 units. And looking at 30 minutes, you see the same trend. So it didn't decrease, but it kind of normalized 0%, 5.9, and then the TENS is actually getting better. So they're actually improving even more, 9% change. Improvement at least. And then at 45 minutes, you still see the added benefits compared to the control group, so quite significantly. This is definitely something I learned from listening to other people talk. Credit to Meredith again. And I actually tried it. I got 2 ACL guys, particularly on the football team, which you may know who they are. And crazy, but one guy came in saying it's a little painful, pushed about 60 pounds as I got some front knee pain. We did it, and he was pumping out hundreds like nothing. And then we only did 15 minutes of TENS and cooling. Same with the other guy. He came in. We did a lot of, he chased me around the field the day before. He said my knee was really hurting. So we came in. I said, let's just try this out. 15 minutes of it. And he says, oh, I feel good today. He was just doing everything. No problems. So from those short experiences and just trusting the research, I'm actually a big advocate of this. The downside from clinically is like, I'm not going to have them come in and waste time, right? So I just tell them it's a passive intervention. I just tell them come in 15 minutes ahead and I'll get them set up. And our game rates are probably going to be in higher use. So,
You're totally maybe getting to this, but like mechanistically, have they proposed something, or like what do you think?
Oh, I don't, man, it'd probably be super confusing. I assume some kind of pain inhibitory complex system. That's what I'm thinking.
Okay.
Yeah.
Cool.
But I don't have a good answer for that. I don't know the topic that well.
Okay.
Yeah. But Brian Peter-Simone in 2009, both articles. I can send you those articles too to read it. Yeah, that's crazy too. It's been around for like more than 10 years, and I was like, oh, it's new to me. So I found that useful. All right, and the next one, who does balance training? Hopefully everyone. Okay. What system did we say uses more of the that people with ACL injuries use more of? Or actually, what are the 3 systems? Anyone shout them out? Vision, inner ear, vestibular, and then proprioception. Okay, so it's metasensory called. So balance training, if someone relies on their vision and that's overcompensating, what would we want to do? We don't want to make that better, right? So what do we do for like a concussion testing to challenge the vision more in the vestibular system? We have one on a pad, right? So we do the opposite for somatosensory. So early in rehab, and there's time and place for it, but we want to do not balance training, but we want to do somatosensory training. Come on. Oh, there you go. Nice fancy animation. All right, so it's metasensory training instead. So we have to be very intentional about what we're doing with early and late rehab. So again, these are all the three systems. But if we're using these pads, we're actually building their compensation and not restoring that somatosensory system. So ways we can do that is have them stand on a firm surface, but have them do tasks. Jenny's probably sick of me. Everyone's sick of me throwing cones around. But when you have them focus on cones and eye tracking, you're taking their vision system away from their balance system, and you're trying to make them rely on proprioception system. And we're going to do a lot of that more when the patient comes in here today, and Ryan can help us out using this board as some fun games too. And then you can also learn motor learning principles. This is a whole talk in itself. Caitlin has presented on CSM about this too. But I will guide you guys to 3 really good articles talking about just motor learning concepts using external cues. But one thing they argue is one concept is interacting with the environment. So again, how many times do we watch our person do a squat and they're just like doing this or looking at themselves in the mirror? And then compare that to sports. You see, I hope no one's running like this, right? Like they have to interact with the environment. So we can introduce that pretty early on in rehab. So we can have them engaging in some kind of cognitive task during quad sets or straight leg raises or knee extensions. Or once they can start walking again to induce knee flexion, we can have them kind of reach for the cones down rather than try to tell them bend your knees more. That's not going to really help them out. Again, using strobes, which we'll use later, they're going to have to, we'll get into this in part 3, but take in more information. They don't get to use their visual system as much. They kind of have to reduce the information they get from the environment and really kind of feel out and use their somatosensory system in functional movements. Some of the things they talk about is external cueing. We all know it. Actually, who gets 8 hours of sleep here? No one here says they did. Okay, it's like impossible. So I feel like external cueing is like sleeping. We all know we should do it. We each tell each other, hey, external cueing is better. I don't think many of us do a good job of it though. And I'm the same way. I'm definitely guilty. I try to be mindful and I tap into it when I'm really having a hard time with someone, but I should do it right from the beginning. And so this one is just here for you guys as a resource on the handouts, but it gives you internal cueing with commonly used exercises and provides ideas for you and also things you can use to help with learning. And what that allows them to do is, again, it interacts with the environment, and they show that it just becomes more automatic. If you have limited brain resources, it's going to take less resources to help them learn that task. It becomes, they learn it faster. Other things they learn is explicit versus implicit. So you want to be very meaningful about their movements to them. I'm doing a study right now where I'm having someone look at a leg press and imagining a certain thing. I never even considered that some people never leg pressed before, right? So like, how are they supposed to produce more force if they don't even know the concept of it? So this, you could talk about if it's a soccer ball, bring a big ball between your legs, or they're both imagining it and you're relating to something important to them. If they're going to tap on a memory that's already developed with that movement, they're going to perform that movement easier rather than develop a new movement. Well, you could argue same movement, but you're trying to tell them new directions that they're going to try to sort through in their brain. So you want to relate it to what they already know. They're going to learn that movement a lot faster. And then you want to give them self-selection. So they should be able to choose stuff, different environments, exercise in the dark. So Winston, we should open this place. Throw some footballs around there, guys, just tell them to run a fade and hope for the best. But you want to vary the environment just a little bit. And that's the hard part. You have to figure out, is the motor task looking ugly? We probably need to decrease the challenge in the environment. If we want to just challenge, if the point of it is just to challenge them in the environment, then we should be willing to let them experiment a little bit with it. And they're going to better understand and normalize and self-cue themselves as far as what they feel is right, and then what you can do with the results. At the end, did you get your outcome despite how it looks and how we taught you? There's contextual interference, so we're all familiar with the different types of training or programming for like how you learn a new skill. Contextual interference just means it's a lot more of the random. So as it's more randomized, they're going to get to return that task and learn it better. It is not what Dame Lillard is doing right here. It is not play a million different sports, doing just crazy things despite what you see on TV. So there's random to it, but it's similar tasks and tasks that they would use. You're not just throwing things in there to be cool and flashy with. But man, is he good at basketball? So I think this might work. Don't quote me on that. What a guy. All right. And then something cool that's emerging is augmented neuromuscular training. So this isn't quite out there, and it's pretty expensive, but what they did in here is they had someone do a drop landing onto a force plate. And for this experiment, they had a big old screen that they use for visual feedback, but sometimes it's in virtual reality as well. So what they did was on the force plate would detect ground reaction force, and they'd have sensors indicating knee valgus. And their role was to cover that whole thing with a square. So let's say they hit valgus, that square collapses. So they're going to have to use that information to figure it out and try to get in a proper position. Let's say ground reaction force is too high, it might shrink here. So they need to line softer and have it expand and fill that square up. And from 6 weeks of training versus a control group that did not use that training, they found that there was a higher signal between the communication portion of the brain. And then when you look at percent change in peak knee abduction, so actually the biomechanics of it, there's a strong correlation between those who did that training and those between those who had a higher activation of this area and connection to the biomechanics there. So again, that's a cool tool, but the end of it is you're letting them interact with the environment to learn the skills in front of them. So that's a lot, right? You're always using an environment. So now we're going to go into, well, first of all, does anyone have any questions on any of that? Negative? Okay, cool. We're all good online, Jason? All right.
I have a question.
No, what's up, Travis?
Did you see anything in the literature of individuals that use like neuro-stem? Did that help at all with the neural pathway? Did that change at all?
So you mean TMS?
Yeah.
Yeah, so TMS has actually been shown to increase quadricep activation. The problem with it is like the procedures when you're just sitting there and it takes hours and frequent treatments. So I think that's a barrier to it. But they did show that by adding, like using TMS not as a symptom but as a treatment, then you can actually increase activation there.
What about like Russian stem? Did that change?
Yeah, so like NMES,
Yeah.
that would increase the quadricep activation. Recommended at least. Yeah. So and that was the A grade evidence I showed.
No, I was just wondering if is that the evidence for like the H pathway with the ratios?
Oh, that's a good question. I would think that's the spinal reflexive pathway because you're inputting signal to get a motor output. If anyone's online and thinks it's wrong, please correct me. We have some PhDs on there right now that know this stuff. But I would think it's spinal reflexive pathway. What's up, Zach?
So this is me just not knowing the evidence very well. So
Yeah.
so with NMES, what does the evidence say? What are your recommendations on like parameters, like how to use it as far as like settings, time? Like are they activating volitionally with it? Are they doing a task with it?
Yeah. So one of your former schoolmates, Bailey Lancer, presented on this on a little YouTube channel of mine, and from what I remember. She has very specific settings, but it was like it's what we use clinically is a little different from that. But you do want to do a maximal contraction as you do it. A lot of people do it with isometrics. She did show one study where you're doing like a step down task with it on. I think it goes for about 15 to 20 minutes. I don't know if you want to do a step down task for that. But yeah, so it does have specific criteria or parameters that you want. Our machine, I just put it on Russian. And then pads, I think Dr. Snyder-Mackler wrote an article about like recommendation of using the really big pads overall versus the little pads we have. But yeah, you definitely want to do it with exercise, maximum traction. They recommend at 60 degrees because that's like the best point where you get the highest activation of the quads. I do 90 just because I don't feel good with my eyeballing. So I feel good with 90 better. And it's easier to fixate the strap. Sometimes it slides up and down the poles, 60 is hard to get. But I'll just have I think the work to rest ratio is 1 to 2 is recommended. So 10 seconds on, 20 seconds off. Oh, that's John.
Thinking about your question, Travis, that spinal reflexive pathway, that's a better argument for more like a biofeedback unit rather than a Russian stim. You're getting that feedback so that you control the drive, as opposed to this external thing that's driving it, feeding into that. Technical chronic damage trigger. Pushing that.
Yeah, and I think there's good support for biofeedback as well. When I first got here, I tried to get a free trigger unit for us, but it didn't work. I was trying to use it for research. Like, we got to measure like central activation ratio, and they said their new unit is actually gonna. I'm not paid by them. Their new unit is gonna have the capability to actually test that. But yeah, biofeedback would work equal because you're giving them something that some kind of feedback from the response. Thanks, Sean. All right, so I want to go into this because people, when you say dual task, a lot of people kind of clump it in the same together. But again, we all do it. We'd be very much more intentional about it based on their deficits there. So it actually looks like this. They're kind of separate compartments, but they certainly have some overlap. And we'll kind of go into each of those. So an example of vision training would be like a Brock string. So Brock string, you're working on basically when your eyes come together, that's called vergence, and when they come apart. So tracking objects. So what you do with this one is you can set these little bold predefined distances, and you can just work on your eye muscles, working on depth perception there. So that's vision training. Cognitive training is just math, complex math. You guys hear me scream math problems at my athletes all day. Dual tasking would be two physical tasks. So a lot of people think like standing on your leg and catching a ball is a cognitive task, but it's a dual task. There's not much cognition in it. They're just simply catching the ball and passing it back. So it's the same thing as walking chewing gum, vacuuming, rug, wiping, iron, all the good things SpongeBob usually does. Visual dual tasking, example, imagine in the Brock string, and then in your peripherals, you have to identify when something appears, you have to touch it. That would be an example of that. So there's a physical task, there's a vision task, and you're doing two things. And then cognitive dual task. So this requires no action, but you're just thinking. You're only saying even numbered answers aloud when you're given math problems. So you're trying to hold in any odd answers, and then you say the new answers. And then you use synaptic cognitive vision training. So you only touch circles that have objects. So certainly you are reaching, moving your arm, but that's a novel task. So it's not really much of a complex pattern. So you're really just testing your thinking on when to do it, and then also looking and identifying where you can do that. And then there's cognitive visual dual tasking, which is the final one. So there's imagine tempo squats. So they have to listen to the tempo while squatting, while only calling out the even numbers on warm colors. So if this is the even one, it's a blue background, can't say it. So they have to go through a series of steps of thinking before they can do it. So I have a slide. If anyone wants this email to them, I can send it to them too. But they're constantly looking. And they do, if it's on a big screen, they do have to kind of track that object a little bit. So you can see here, this one, Mr. Anthony is just fixed. He's doing what everyone does in Rehab, right? Looks at their foot. And then now let's give him that task. So he's already got a major sway. His tempo is good. So his brain is choosing one task to focus on, but he might be losing it. He might be saying the wrong answers at the wrong time. He might be losing balance there. So again, the hard part of this is finding at what level they are. Are you working on the coordination point? If so, if he's losing tempo, then I'm going to make it an easier task for him cognitively and let him focus on there. If I want to challenge this mentally, just let him kind of work through it, then I'm going to let him get a little ugly there and kind of work through the problems and get everything correct there. And you can also make it so it's perfect. That's a hard part though. So here's some exercise for late stage. So this is a history of 20-year-old college engineering major. He was playing football with friends. 5 months S plus ACL with a meniscus repair. His current goals right now are to restore quad strength, progress through impact, work on dynamic balance, typical stuff, work up our sprint volumes, hamstring strain prevention later on for later stages, sport-specific drills, and then biggest thing, instill confidence, right? So with these exercises, I'm going to show you how we're using it to progress through impact and dynamic balance. We're going to use some of the properties we looked at, and we're also going to look at sport-specific drills to instill confidence too. So here's my college engineering major. So the first one, I just said jump over the hurdles. Okay. Go. So here he has some forward bounce. You see a little double hop there. Nice stiff landing, looking straight at his leg the whole time. Man, he's so proud of himself. Look at it. Oh, he's so happy. Okay. All right. Next one, I said, hey, guy, try to look not at the hurdles. Just look forward. He's probably ready. I'm always ready. Let's go.
Good. Look forward.
Same thing. Doing it pretty good. Except has double hop. not so proud there. Smell off there. All right, now all I did was add something that he for sure has to look at. So I said, I'm going to do this, and you have to call out the numbers here. So it's a simple cognitive task. You're just calling out numbers. You have to make a decision, but you have to stay fixed on that the whole time. If I want to make it harder, I could also move around, so he has to track me, but I want to kind of find the level he's at. Let's see what happens when he does that. A lot more hops. Oh, little mistake there. Oh, a little mistake there. It's all good though. He tried hard. That was actually the third video I took because he literally knocked over 5, all 5 of them, like continuously. And I finally that was like the best trial I got. So even just adding a little bit can go a long way with helping them. Looking at this though, which progression would you actually have them on? Based on how he was doing on these tasks. Number 2, anyone else? Okay. I'd actually argue, and I actually put him less than level 1. He was landing really stiff. He couldn't even get that. I'd rather him maybe not look at his feet, but maybe just jump in place and just focus on a good landing there. And then I might focus there. So hindsight, I'd actually regress him quite a bit. But I would say I agree. I see this one where, again, if you're challenging him cognitively, this one's obviously too hard, and this one's appropriate. So again, different things. If I want to work strictly on balance, I'm going to take him away from this. If I'm willing to let him explore a little bit, I'm going to work on level 2 with that one. Another thing that we like to do is, well, I like to do is clock yourself out. It's $2. Sometimes it is free. It was made by a PT, but you get these complex tasks, which we'll play with later. So you could set the steps per minute. You could set the duration, and there's several modes. So this one, just you could do a little, you could tape around 12 areas. We'll do cones later. You can either have them touch with your hand, you can have them jump, you can have them lunge towards it, and the app calls it out for you. So while they do that, it leaves me free. I don't have to think about saying a number and seeing if they got it. I just let them do their thing. They can literally look at the app themselves or put it on while they do the task. I could, my hands are free. I could pass balls to them. This is harder. So you still have level 1 and 2, but it calls out months. So now it's a 2-step process. Okay, so what month is that? What does it coincide with? Which way did I go? That's a more complex task. So they have different modes like that too. I like to use a Bluetooth because phone audio is never loud enough. So I always hook it up there. For this example with this athlete, I used colors. So it's 4 easy ones, but here's the hard part. Which one's the blue one, guys? Right? So these ones are downloadable for you guys. Just email me if you want copies of this. Sorry, we are leaving the beaver logo on there. But so I'll have the app call it different colors, and I'll have them do a movement. And then midway, though, I'm going to say background color. So now they have to figure out when it calls yellow, I'm going to go here versus here because that's the font color. So for this guy, he plays linebacker. So I'm going to set it up to replicate the gaps, and then I'm just going to tell him go there. And we're going to address sports specificity without acting like making him do all these crazy. I'm not going to make him put on pads or anything like that. But he's getting into his movement. He's staying low. He's going to work his quads, and you can see it here. Excuse the heavy breathing. It's really excites me, you know. Font. Oh, got him. Dumbbell. Background. So yeah, whenever it's just me and him, last patient at the clinic, it's a party. Yeah, we get all this out. We use all the equipment, but that's options you can use to help them out. You can even just put it on the wall. You don't need these hanging up there. But again, his comment after, he was like quads on fire, and that was like 30 seconds total. So part 2 summary is rehab specialists already do many of the effective interventions and would enhance neurocognitive changes with more consideration of concepts. So again, we're all doing it, except we just need to be a little more thoughtful about it. And then not all dual tasking, that is incorrect. All dual tasking is not the same. And then one task can accomplish multiple goals based on variables manipulated. So you either have to change the physical component of it or the mental component of it. And complex concepts don't need to be treated with expensive equipment. You can use cones, you can use external viewing. There's a lot of options that you already have. Any questions there at all? What's up, Caitlin?
And this is kind of like a chronic question, right? But like in terms of when to progress and how to progress, obviously you're basing that off of individual athlete deficits and goals. Mm-hmm. But for example, with this guy, like when would you progress into a more complicated task and what might that look like?
Yeah, so it's exactly that. It's what is your criteria for them to pass? For that guy, I'm looking for him to land with a deeper knee flexion angle and a solid bounce where he's not hopping around. So if that was my criteria for that exercise, I'd keep him on a very low cognitive load, still have him focus on external objects, but really focus on that. But again, if you're just like, yeah, we need to work on this, we need to progress rehab. If we don't, you're going to fall behind. It's going to look ugly, but at least just add this cognitive task in, and then we'll work on that with other parts around the session. We'll do maybe like deep squats with 2 legs to get you used to that pattern, accustomed to it, and everything like that. So it's going to depend on your criteria and your goal specifically.
Yeah.
That's a hard part. That's a nuance that's super hard for us to figure out.
And I would think too, like, because you want to progress the basics, right? Like you're talking about. And so making sure that you're maybe like doing that and doing some of this cognitive stuff and then eventually marrying them, or marrying the cognitive piece with like a super low level task like a leg raise or a quad set, and then building the patterns. Yeah, I like all of this stuff. I think I really struggle with like when to implement and like what criteria I have to then progress and make it more challenging.
Yeah, and that's a challenge I have too. Like I'm going to be lecturing on this, and you look in the clinic, you're like, what are you doing? He's like, insane. I mean, you guys see me do some of this stuff in clinic, but not as frequently as I should, because you can start like you can even do tempo straight leg raises right off the bat.
Right.
Tempo quad sets. You can do a lot of that. So it really is more or less challenging. The article literally just came out today talking about how as PTs we do not do well at adapting research. Talks about that 17-year gap despite all this ACL prevention research out there. So one thing I'm just realistic with my expectations. For this past month, I did the whole icing intent before. This whole past year, I integrated more of the clock yourself, the colors. So just expectations that I'm not going to adapt it all at once just because I forget. It's hard to break my habits. Time constraints as a clinician. You're trying to think of all this. So just being realistic with yourself that it's not all going to happen at once. But still try it out. And if, again, this is to really help you guys get stuck. I think everyone does a good job. It's just when you get stuck, you have a bank now. Okay, well, let's try E-stem, but let's try it at the beginning. Or let's try this balance exercise, but let's add this into it to help you get a little better. So Travis.
You know, it might be helpful. Kyle and I are spending this year to develop exercise progression for every basically joint. It'd be cool to team up with you and try to have you attend some of the meetings and we come up with progressions. And those progressions, you know what I mean?
Yeah.
You can utilize your expertise to come up with some progression in there.
Yeah, there's this little another presentation I did. I had this little grid. It's like I told them like PTs are like DJs with exercise, and this too. Like once you increase something, you have to decrease something at first, but then you kind of play around with it. So if you do want to go that route where you have your progression, what I have is like instead of exact things, I have like level 1 type task or concept. So like for me, I don't think about like I'm gonna do a color with a number and that. I don't think of it that way. I think I'm gonna do just like writing board questions. I'm gonna think of a 2-step process. Right. So I'm not just gonna have them do a math problem. That's fairly easy. I'm gonna make you tell me if it's an even number. So I think that way you guys can do that one, and I'm certainly happy to sit down with you guys and talk about like, okay, well, what are examples of two-step question or task versus three-step and all that more advanced stuff. Any questions there? Nothing? And in that case, we'll take a break. And let's actually, how do you guys feel about 12:30? Because I got to get my athlete here a little early. All right, welcome back, everyone. I'm gonna stay within my little spot so I don't get a camera. All right, so now we're gonna go over vision training and performance, for rehab and performance. So everyone's seen this video, I take it. Who here hasn't seen the video? Oh, perfect. Oh, nice. Okay, so we're sorry, whoever's seen it a million times, you gotta see it. Okay, so I'm just gonna play it.
How many passes does the team in white make?
Ready?
The answer is 30.
Everyone get it?
But did you see the moonwalking bear?
Anyone?
Yes.
No, looks like a moonwalking bear. Yeah, so before I get into this topic, it's important to understand what vision skills and attention skills is. So vision is like, okay, can I see the video? Is it clear? Do I have contacts? Do I have glasses? Attention is, do I identify the things that I need to identify? So that's an example of, you could see the video, but were you able to pay attention to every little thing in that frame? And we're very selective, and I say we're, as human beings, are very selective on what they do, given the task and what they're used to, for what they usually do during the day in their sport. So the quiet eye is kind of, I consider, a vision skill. So what the quiet eye does is, well, actually attention too, but quiet eye basically, if your eye moves and tracks something, you do it very fast, so your eye is quieter. So a good quiet eye, if something that you're paying attention to, you fixate it to it very quickly. And the way they can study that is using eye tracking goggles. So you wear a goggle like this, and then you have cameras that kind of point to your pupils, and you figure out where it is. You have an HD camera sticking out, and it correlates the image with where your eyes are looking. So this kind of technology was used for people who were like interviewing. So they'd look at how long a person spends on a resume at what area, but you could also do it for sport. And this has been studied as early as the 1990s in sport like tennis, hockey, other racquetball sports. What they did was looked at novice and experts. They looked at movements, and back then they didn't have biomechanical camera, 3D camera systems. So what they did was just observations of raters. And what they found is that experts happen to have less jittery movements when they had to react to something. They could identify it right away and make a movement. They also found that experts, again, talking about quiet eyes, they identify using this stuff. They identified that object faster, and they would notice that that athlete would respond when the ball's here versus tracking all the way to their hand. So they're able to make a decision faster. A good metaphor I give is at the NBA level, or even at high school level, played a lot of basketball. When someone shoots, people are already lining up on one side of the basketball court to grab a rebound because they know exactly where it's going to go. One, it's part of the training, so they've been exposed to the density and properties of the basketball, how far it bounces, but also they can track it and they can already kind of predict where it goes as an expert there. So is vision and attention trainable? Studies looked at pilots and not, so in someone who has never done kind of pilot training before and trained pilots, and what they saw is like they did some radar to see, and they had to kind of tap when they had to focus on one object and tap when they saw a certain object pass. And they found that in the beginning, when they compare expert versus novices took a lot longer to find it than the experts, but within 4 weeks of training, the novices increased quite significantly. They weren't matched with experts, but it was certainly trainable. Vision is a little different. You need to probably see an optometrist. You have to get corrective lens. That stuff we can't just train and suddenly my near side and far side just gets better that way. So vision maybe, and when we get to synaptic stuff, we'll break down what vision skills is because it's kind of a combination of everything. But attention, certainly you can train it, and I think that's what makes a very good athlete. They're able to identify what they need to do a little faster, and we'll kind of look at it here. So this is a normal response time. This is probably from motor learning from undergrad, right? So let's say in sport, a stimulus is presented, and time it takes you to identify it. So we have an athlete here, Miss Haley. Let's say a soccer ball comes into play. It's there. She may not be aware of it, but it's there. And then she finally takes her time. She finally identifies it. So that's her attention. At that point, once she finds, identifies that object, she has to process in her head what she's going to do. So what is the angle of the ball? Is the ball in the air? Is it bouncing off the grass? Who else is around it? Will it bounce around someone? So it takes all that into account. And then she's going to decide on what to program after that. So she decides, okay, based on all these properties of the movement, the ball, everything around me, I'm going to do this. And the movement is initiated. So the way this can help with possibly, this is a very long stretch, possibly injury risk reduction, but certainly performance is if we kind of compare it to normal versus train. So this will be the train. If we train attention, we shorten that time. We're able to identify the stimulus quicker, so we can spend more time here. If we do vision training, so expose them to that training stimulus, get them better at the skills that we're going to look at in the synaptic station, they can process that information faster, and then that time decreases. So from the time the stimulus is presented to when they initiate their movement, we can shut off a few milliseconds, hopefully. So imagine that in an injury context, right? So if you know a ball is going to come to you, and you also have to keep in mind when you have to initiate your ankle from not inverting, that's going to be important in injury prevention. As far as performance, that's a no-brainer. You actually see the ball faster, you know what to do faster, less movement. If you do make a mistake, you then have time to correct that mistake with the new motor program. So these are all the different skills skills that, or vision and vision skills that the synaptic station or sensory station assesses. So visual clarity, this is an assessment where they just look at how clear something is. And if you're bad at this, they just simply recommend you go to an optometrist. And then they have contrast sensitivity. So for the sake of time, we're just going to look at what Haley's areas of improvement are, and then we'll work on that. But they have all these different things. Again, depth perception, near far quickness is talking about like eye teaming, how well they work together. Again, that vergence we talked about, reaction time, and then eye-hand coordination. And then again, there's also cognitive tasks that you can work on too, where you identify it and then you decide when to do it and not to do it. And this is the assessment. There's 10 assessments. There's like 21 training modes, correct? And then you can make endless combinations off that. I got into this because when I was first in San Jose State, Shane was the one in the lab picture, but you certainly don't need a sensory station, and you don't need their product, but there are other products out there where you can use certain tools to help it. Synaptic station is just, there's endless possibilities, and you can be very sport specific. So if you don't have the financial means, there's other ways to work around it. And as you can see, it's not that complex to make as long as you know how to use the tools. And then, of course, you've all seen stroboscopics around. That's some vision exercises that we can do too. But basically, would you have a patient run, drop land on one foot, or jump with their eyes closed? Some studies have looked at that. That sounds terrifying to me. I have chronic ankle instability. Hard no, I'd ever do that. So stroboscopics offer you an option to slowly take their vision away in gradual increments so they could get more used to it. So we talked about how your after an ACL injury, your vision gets used more. So this one, your vision gets taken away in increments. So you have to take a lot of information quickly in order to define what your sensory system is going to do to that. So again, it's challenging the visual system. It trains the quiet eye. So we talked about how you have to identify an object faster and then decide on what to do faster, and you're going to make less mistakes with less jittery movements. So in this sense, imagine it's taking vision away, and you'll all get a chance to try it today, except at home. But it'll take away vision at certain increments, and then let's say Travis over there throws a ball. I see the first part. It's probably going to hit me in the face. I suck. I'm going to be flat out. But I'm going to learn from it. And then so I'm going to learn the properties of the ball. I'm going to start saying, wait a minute, if I look at the angle of his arm, then I can make a decision on where that's going to come. So I'm going to start focusing on different things. I'm going to learn how to use that information a little bit better. So it can help train that quiet eye that a lot of experts have. And if you look at this, within the past year, you've seen a growing emerging evidence with this. So there's a lot more coming out of it. I'd say stroboscopics are one of the more truly evidence-based technologies we have out there. Everything that we go over, there's good evidence for it too, as far as like what we're going to go over the sensory station, because there's optometrists who already do this. It's called developmental optometry. So they all did this to help kids with ADHD in classrooms. They to focus on reading so their eyes don't get tired. Sometimes their eyes get tired. It's not ADHD. So there's a field out there already. This is just now us bringing it into the sports performance world. So we can talk over one topic about training the quiet eye and getting information and how it might be useful. This is Danny, it's my co-resident. But for my research topic, I did something called coincidence anticipation time. So it's how well are we able to time something that reaches a certain, that intercepts at a certain time point. So as an example, I'm going to drop a ball right on Danny's head, okay? And when you guys think it's going to hit right on there, you guys say now, okay? I'll say it too, okay? Ready? Now. Yeah, so I was way early, right? So keep that in mind, okay? So that's, we can measure that. So coincidence and anticipation time, there's certain variables you can look at. It can tell you how big your error was, so how far off you were. That's called absolute error. And then there's constant error, which takes a point direction too. So if right now, something I hear Marcia say now, I'm like, whoa, like that's way late. That's probably not good. For me, I was way early. So that's some values you can get out of there. So in this experiment, they looked at people who were trained using stroboscopics versus not. So there were 30 people, 15 in each group. So they did 10 trials. So they used this little beam here, and that beam shoots a light. You push the button when that light hits where they say to push it. And that's going to give us our values there. So they did practice trials on that little machine called the Bassin timer without goggles. And then they did the tests, 10 trials. And then here's where they did it. They did the training. They're turning it into training with goggles. And then one group did it without goggles 50 times. And then they did immediate retest, 10 trials right after, no goggles on both groups. And there was also a retention. This is a retention study, so they did it later. So 10 trials, and then 10 days later, no goggles in both groups. So this is absolute error. So again, this is the average, the average magnitude of error. And if you look at pre-training, both groups are fairly even. And if you look at the strobe group, the error was actually bigger, but interestingly, after you see them actually get better. And then for percentage of early response, again, this is that constant error. They're just looking at how many people had constant errors that were had an earlier bias in the response. And you can see that strobe had a higher percentage and it dropped during training, but then you see this kind of superimposed effect there. So what can we get from this article? Training may be supposed to look ugly. And this is what we talked about in part 2. How it's very hard to define how we dose this exercise. Sometimes you're going to want it looking messy. Sometimes you want the cognitive task way harder. Or other times we want it looking really clean and we want to just introduce a small cognitive task to them. It depends on our goal. But sometimes even if the movement looks ugly, maybe you're just letting them explore. This is that contextual interference we talked about for them to kind of get into, and hopefully it transfers to better learning because they're figuring out different patterns and strategies. And then they also retain improvements, and it may be longer because, again, this is only one training, and it had, well, this graph makes it look significant, but they had improvements from there. Limitations, these goggles were done by Nike. This was a funded study by Nike, so we have to be aware that there might be a risk of bias there. And then they did it on slow speeds, not relevant to sport. Nowadays, that's actually debatable, but I won't get into that because it gets into all this geometry. And then the test and the training were the same task. So my caveat is I would have liked to see when someone trained with random exercises with stroboscopics, because if you train for the test, you're going to get good at that test. So there was between group differences, but I still would have liked to see clinically, I'm not going to have someone on that machine just doing this. I want to see them out and about and seeing the transfers over well. And then the article by Dustin Grooms in 2015 goes over some good techniques to this, but overall, the take-home point is you have to interact with your environment. Simply jumping in place, yeah, that's challenging and daunting, but you don't really have to make any decisions, or it doesn't challenge your somatosensory system as much. You want to jump to certain areas over and over. So with that, overall summary of today is clinical impairments are manifestations of neurocognitive alterations that occur after issues. It's not just simply muscle weakness. Rehab specialists do many correct interventions, but may help normalize neurocognitive changes with new considerations. So we're all doing great things, but now we just have to, again, fine-tune our thought process on prescribing these. Vision training may affect movement, which may assist physical performance and injury risk reduction. However, further prospective studies are needed. And again, I say vision training because it's called vision training, but understand that there's aspects of attention in there as well. Okay, these are my references. This is my email. I can send you guys any of the things we went over today, other articles and resources. Meredith just joined us. I cited a lot of her studies, so you can ask her questions right now too. So questions from the audience and also to the audience. We have a lot of smart people on. This is Ryan's email. He's going to go over some of the stuff during the training. So right now, is there any questions to begin with the part 3 section? Travis, what's up?
Have you ever seen the next version of these goggles where they put strips of tape?
Don't remember those drunk goggles. No? I mean, I've never seen it, but no, I haven't seen them.
I just want to think of comparing the synaptic goggles to those.
Do you know any, Ryan?
I can find some.
I can look too. I did find some in there, like the old super Japanese ones. I just got to swap with the batteries, but they're an option. It's not. I mean, you'll see Ryan get into it, what his can do, but it's not. It's definitely not like what's an option.